Hello, everybody. We are having our 30th intergenerational meeting with very important guests, and they will be talking about their early years. Once upon a time, our senior educators were medical students as well. And one of our medical students recently graduated and started working in psychiatry in Istanbul, İrem Keçeci. She will moderate this meeting. I'm leaving the floor for İrem. Thank you, İrem.
Thank you, Dr. Coşkun. So, welcome everyone. All. I'm İrem Keçeci, first year psychiatry resident in Istanbul, Turkey. And from my medical school years, I was interested in psychiatry and I have tried to participate in the events organized by SEED, Student Empowerment Education and region. And then I had the opportunity to meet some senior educators. Like we have Dr. Jenkins here, Dr. Afsal Ceyvet, and Norman Sartorius, and Unai Zanias, and I think we will have David Barun soon. And they all are important persons in psychiatry, and they will be important examples for us, for medical students and for residents, I think. And today is a great opportunity for us to learn about their experiences. So I will try to give some brief explanation about their careers, and then I will try to ask some questions that both come to my mind and both written by the students that participated in this event. Like that. So welcome again. And I think we can start with the presentation now.
Who is Bartu?
Bartu is. Would you like to say something, Bartu?
Hello, Dr. I am a medical student in fourth grade. Can you hear me?
See people's faces.
Sorry, I couldn't understand.
Let's see your face. Yeah, please, İrem, continue.
Okay. Dr. Wilson, I want to share a presentation, but I think you should give me some permission for that. It is okay now. So can you see my screen now?
Yes.
Okay. So today will be our 30th intergenerational meeting, and our topic is Once Upon a Time, Senior Educators Were Medical Students. We know our medical educators and psychiatry educators as only educators during our medical curriculum. And we sometimes thought like they were always educators or experienced persons, but they were a medical student once upon a time. And I think they will all have some great experiences about medical school and early career year for us and for medical students. And it will be great for us to hear them to be motivated for our future. So here are guests for this meeting. Dr. David Barun. Is Dr. David Barun here yet? I think not. Okay. And we have Dr. Afsal Cevdet, Dr. Rachel Jenkins, Dr. Unayza Niyaz, and Dr. Norman Sartorius here with us. And some medical students, both in here and both in YouTube live stream. So you are all great educators and all psychiatric legends for us. And I don't know where to start, but I will try to use this list here. Pardon, Graham. So first of all, Dr. David Barun. He's a professor of psychiatry and provost and senior vice president of Western University of Health Sciences and emeritus professor of psychiatry at University of Southern California. He has served in National Institute of Mental Health and taught in medical schools, nursing schools, and dentistry and all. And he is a board certified in psychiatry and neuropsychiatry. Okay. So he also has worked in VPA, World Psychiatric Association, within different sections, and was chair of psychiatry. I think.
Please close your sound.
Microphone. Maybe somebody is speaking also. It's okay. And he has also worked in the education in psychiatry section of World Psychiatric Association and was chairing on psychiatry, medicine, and primary care section in VPA. And Dr. Afsal Cevdet, he was recent president of World Psychiatric Association from 2020 to 2023. And he is interested in social and transcultural psychiatry, psychosocial rehabilitation, community psychiatry, and also psychiatric education and teaching and training. He has also worked in different organizations like Pakistan Psychiatric Research Center, Foundation House Lahore, and he has served in the Royal College of Psychiatrists, Psychiatrists in United Kingdom. And he was past president of Asian Federation of Psychiatrists Association and World Association for Psychosocial Rehabilitation. And now he's a consultant psychiatrist and a honorary professor, Institute of Applied Health Science, University of Birmingham, and honorary associate clinical professor at Warwick Medical School. So here we have Dr. Rachel Jenkins, a professor emeritus at King's College London. She has different titles like psychiatrist, epidemiologist, and mental health policymaker. She is interested in both mental health policy implementation and also training and research in psychiatry. And she has worked in different communities like World Bank, African Development Bank, and I think, and in the World Federation for Mental Health, World Psychiatric Association, and other international and national organizations. And now I think we can change. And she's also interested in suicide prevention strategies, and she works in a National Suicide Strategy Advisory Group. We have Professor Unayza Niyaz here from Pakistan. She is adjunct professor of behavioral sciences and psychiatry in the University of Health Sciences, Lahore. So she is an honorary member of World Psychiatric Association and founder and chair of section of Women's Health in the World Psychiatric Association. She is interested in traumatic stress and especially for women, children, and refugees. And she was past advisory in psychiatry in College of Physician Surgeons of Pakistan. And she is president of Pakistan Society for Traumatic Stress Disorder. And here we have Professor Norman Sartorius. He's defined in even in Wikipedia like the living legend of psychiatry. And so he is specialized in neurology and psychiatry and obtained master's and doctorate degrees. He has worked in both Croatia, London, and Geneva, and elsewhere. He was a former president of World Psychiatric Association and director of Division of Mental Health of World Health Organization. He also was president of the Association of European Psychiatrists and president of the International Association for the Promotion of Mental Health Programs. He is a senior associate of the Faculty of Johns Hopkins School of Public Health in Baltimore. And he is an honorary member of numerous professional organizations and advisory boards, both national and international. So we all have great professors here, and they all have lots of papers and chapters and everything, and lots of other career details that I haven't said, but I want to pass the word to them. So I don't want this part to be too long. So I had tried to make a little summary for you, but they all have great qualifications that we don't have time to talk about here.
Meeting room.
So if it is okay for you, I want to ask some questions that we are curious about to you, but before that, do you have anything that you want to say about this meeting or to us?
I'd like to ask that people who are present disclose their face. I mean, we have done it as well, so why don't we also see who are our partners here this today?
Yeah, right.
Are they sleeping, or is there some other reason why they are so shy? Are they undressed? Do they have funny faces? Are they without makeup? I like these people's faces. And Mr. Bartucelik, you are special, no?
Professor, I activated my camera, but as I see, there is a just black screen, and I'm going to attend from my telephone. now.
Okay, fine. All right.
I am coming.
Right. And Kashmin? Nothing. We have two more unknown spies among us. We are incognito, riding. Ah, bravo, Bartu. Nice to see you.
Nice to see
You
you.
shouldn't hide your face. You look very well.
Thank you. You look very well too.
Thank you.
Your questions, Iran.
So I think we can pass to them. Kashmin said that I'm attending from my workplace, so unable to turn on the camera.
Okay, fine.
I think we can continue now. So,
Mhm.
First of all, and Yağmur said something. Unfortunately, I do not have an available space here in the dormitory, therefore I won't be able to. Okay. Okay, we can continue. So my first question is, like, there are lots of medical students thinking about making a residency in psychiatry, but nowadays it's also popular for our country and for other countries is to make residency in another country elsewhere, and I was also curious about this, and now I saw that medical students are also curious. Is it possible to, or is it convenient to make psychiatry residents in elsewhere than your home country in another language that is not your native language? What are your recommendations about this? So I think you haven't all completed your medical school and residence in your home country. And I also think that it will be important for us to hear your perspectives about this because it can be intimidating for medical students. So my question is, do you think it's possible to make a medical school education or residency in different countries? And also, what are the differences between psychiatric education or medical education between countries? What are the variations and how does they affect people? And what are your thoughts on this?
I think we should ask Dr. Javed who just recently been writing a book about it. So maybe he could start us off.
Okay.
Well, thank you very much, sir. And I was just wondering when you asked all the participants to show their faces, probably they were scared to be seen by a person like you who has really shaped the future of psychiatry in a very big way. First of all, let me thank Professor Koskan and all his team for inviting us. And it's indeed a pleasure to be present with Professor Sartorius, Professor Jenkins, Professor Niaz, and all of our other younger colleagues. I think this is a very commendable effort that you are inviting people to reflect on and to give some messages about why we should choose psychiatry, what are the current hurdles facing for having further postgraduate studies, especially in those countries where we have got limited number of psychiatric education available. I must say that psychiatry is probably one of the fastest growing medical specialty. And unfortunately, we are the victim of a few forces. I would say the most important aspect is that, unfortunately, unlike icons of psychiatry like Professor Sartorius or Professor Jenkins, many of our generation were unable to impress our younger graduates that psychiatry is the specialty, and we were unable to have a sort of a role model. There were many reasons for that, because within our own specialty of medicine, psychiatry was not considered as an integral part. And I think some of the issues which we are facing now, that is also due to our psychiatrists' lack of engagement with other medical colleagues, psychiatrist engagement with the medical students, with the developing the postgraduate students in their own countries. I graduated from Pakistan. I had my early post-graduation from Pakistan, and then I came to UK. I was lucky that our medium of teaching was in English, so I didn't find a lot of difficulty in terms of understanding and learning about some of the advances in this field. I feel that scene is changing. When I was in Pakistan, there were only a couple of hundred psychiatrists. Now the number of psychiatrists, the trained psychiatrists, have almost gone to 3 times. And it is so pleasing that the postgraduate departments of psychiatry in various institutions are having more people who are interested in psychiatry. I personally feel that there was one factor which really diminished the possibility of adopting psychiatry as a career, because as medical students, we were not that fortunate to have exposure to psychiatry and mental health. Many of us from those countries where the psychiatry was practiced in a very old-fashioned way. Our concept was psychiatry confined to mental hospitals. So that was something which really kept us away. And we never believed that psychiatry is a mainstream, a part of the mainstream of the medicine. The other issue is that in many countries now, we are losing our contact with our medical specialties, especially neurology. I mean, as you were mentioning, Professor Sartorius is among those people, and I'm sure Professor Jenkin and Professor Neza Niaz as well, that when we were appearing for our postgraduate examinations 40, 50 years ago, neurology was an integral part of our examinations. And that was keeping us in line with the medical specialities. So these were some of the issues which we have witnessed, but now the scene is changing. And I'm glad that more departments of psychiatry are appearing, and many subspecialties of psychiatry are bringing us closer to the general medicine. There are a lot of advantages our current postgraduate students and medical students are having. 30, 40, 50 years ago, we were depending on going to the libraries, searching the journals, and we didn't have enough resources to find out the literature. Now, for our trainees and medical students, it is just with a click of finger that you can access all the information that can actually teach you psychiatry or at least bring you some insight into this particular illness. So I think what we were lacking when we were medical students, that was a lack of reasonable exposure of psychiatry and mental health to the medical students. So that was one major aspect. The second aspect was that we were not considered as an important specialty. Now, with all these epidemiological data, with all the current information, now we can say it very openly that look, 25 to 30% of our population suffer from one or another type of mental health problem. So this means that within the general population, our share for expertise is being recognized more and more. And the third thing which I feel is now gaining more importance, which is good for psychiatry, but we are not in this position to use that for our favor, and that is the awareness. Awareness about mental health problem is increasing among general population. Unfortunately, we have not been able to take patients, carers, and users of mental health services on our site. I mean, many of us has experienced that when we are attending congresses, sometimes more people are raising slogans outside the Congress than the people who are attending the Congress meetings. So I think these are some of the areas which we were not lucky enough to have our exposure, but now the scene is changing. And I do hope that psychiatry will gain more importance and more recognition in medical education, in our future teaching and training programs.
Thank you, Dr. Javid. So, do you want to say anything else? I think Dr. Niaz want to say something. Okay. We are listening to you, but your microphone is off, I think. We can't hear you.
Hello, good morning, and Assalamu alaikum, and a very good Friday morning. This is the day when we all pray. This is like your Sunday, we are Friday. And I wasn't somehow, I got Buland. I have to say something very special about Buland. He is the most inspiring colleague who always gets me into all these discussions. I mean, nobody else has been so inspiring as Buland. And I had to come primarily because of Buland. So I'm here. I'm sorry. I agree with Professor Sartorius that yes, I didn't put the lipstick on. I didn't have my hair combed, so I was waiting for some time. But I also, before I go, to Professor Sartorius, tell me what herbs you take or what concoction of things you take. You're just the same. So handsome, so young looking, so perky. It's amazing. You have to tell us a little something about it. You're brilliant, in everything, looking good and, great role model. And look, Afzal, I, and even Rachel and all, we look as if we've, gone through life. But you look, whatever, 25-year-old handsome guy. So anyway, he'll answer later on. Sorry. Now, I just like to say that Afzal and I had slightly different. We are both from Pakistan. I'm from Karachi, which is a cosmopolitan city, used to be the capital of Pakistan at one time. And I think the basis of psychiatry actually was started by Professor Rashid Chaudhry, where Afzal Javed also worked in Lahore, and Professor Haroon Ahmed, and other few psychiatrists who went to Maudsley on WHO scholarship. And at that time, they got their DPMs. And at that time, college hadn't started. And the head of department there was a neurologist, Zaki Hassan. Frankly, and the unit was just superb. It was just like Maudsley, I would say, not really, but sort of. And in some ways, like the Royal Free Hospital academic unit in psychiatry, where Gerald Russell was there. And Gerald Russell used to be the dean of psychiatry at the Maudsley. So I was just extremely lucky to work in these places. And I'll tell you how it all happened. I was a medical student, and my father died at 17. And I wanted to do something dramatic. He died of heart attack, so I wanted to do cardiology. And then I thought cardiac surgery and et cetera, et cetera. But when I was doing my house job, et cetera, I realized you have to stand for hours, you have to have so much strength, and et cetera. So I felt that this wasn't me. I mean, surgery bit wasn't for me. And then they said, okay, the second choice in Pakistan, there's no post-graduation, so you do anesthesia. This is Professor Haroon, in a way, my great mentor, who's still alive and very, very ill in Karachi. And he said, well, okay, you do anesthesia, and then maybe you can be transferred to neuropsychiatry unit, and then we can somehow get you back in psychiatry. Anyway, I did anesthesia for a short time, and believe me, I hated it. I saw the neurosurgeon who was great, who also wanted me to do neuroanesthesia. He would shout at the anesthetist and say awful things. Oh, she's not doing the right thing, and I won't use the rude words. He even said quietly, cow. And I felt awful. And I said, how dare he say something about this nice lady? And so they were rude. The surgeons were rude at that time. So anyway, luckily, whatever happened, Professor Haroon managed to write to Gerald Russell for the clinical attachment at that time. There was no PLAP, nothing. And I was selected. And I was very lucky to get clinical attachment at the Royal Free Hospital, Hampstead, with Gerald Russell, the famous bulimia guy. And who also, of course, used to treat Princess Di. And Prozac came in London, in England, because of him. So I'm very proud to have worked with him. And he became like my godfather. And I have to say, luck, fate, or whatever, and God Almighty, because I'm a believer, I think it works. I never even dreamt of things which happened to me. So all these years, while I was in England, 7 years, I had no problem. And I think that we were just talking about, you were saying that we should have medicine in or local language, or we should have, an international language like English. I honest to God believe that English does play a very, very big role. And we were decolonized, as you know. The good thing is that we had very good convent schools, and we were good in English, and I was always very good at writing, etc. So I think that played a very important role. And so presenting conferences, being with Professor, I was like a little protege of Professor Russell. Wherever he went for anything, I became a senior registrar later on there. And so I was there all the time. So these were the advantages. And there I met Paul McHugh, who was he was the registrar at the time, and Gerald Russell was at the Maudsley dean. And so he had great regards for Gerald Russell. So he sent one of his colleagues, Marshall Paulstein, for sabbatical. And interesting thing is, I have to say that at that time there was a lot of bias. He was typical American, a little mustache and a little fat, and there were all these very aristocratic British, all from Winchester and places like that, and they were all tall and good looking and wearing three-piece suits. Me, 90 pounds, brown, but I did my best to wear three-piece suits. I went everywhere to just fit in. It was all, that was the only girl at that time. So, but everybody gave me a lot of encouragement. I was treated as special. And from there, he couldn't do the sabbatical in that 1 year. But he asked me, and I was a senior registrar, I used to make the rota. So I asked all the registrars, and he wanted to do a study on depressed patients of cortisol levels. So I did that. I managed to get him the samples and everything within a month. So he became very fond of me. And funny enough, all my classmates during that period used to go to America, because America was the place, and they all did the ECFMG at that time, which is called. Now it's, I think, different names are there. And they went, but my mother didn't let me go because I was single. And a big story. But anyway, I was just about to leave England because my mother wanted me back, and typical Eastern mother wanted me to be married. But Gerald Russell said, "Well, look, you should go and work for a year in a large mental hospital." So I worked for a year in St. Bernard's Hospital. And believe me, so it was a wonderful experience, and I would have got a consultant's job. But when I heard of Johns Hopkins, it was like a dream come true. They invited me, and it was a dream. I was invited in every department, and Marshall Falstein, I just cannot tell you how grateful I am what he did. Hey, he and his wife met me at the airport, at the Washington National Airport. They picked me from there. They kept me at their place, and I went around 3 days, meeting all departments, and everybody offering me job because I was Gerald Russell Senior Registrar and could speak well. So I think depends on your luck, on your contacts, and bit of fate also. And then of course I was hyperactive because I was doing things. So this is my story. But unfortunate thing is that when I did everything, and I was going to be, I was assistant professor, and I was working with Paul Snyder also, and he got the, I think, Nobel Prize. And by the way, this mini mental state examination thing was developed during my tenure in the liaison psychiatry. So I'm one of the whatever person along with to Marshall Falstein in that. So being in all these important places and being in important whatever research, etc. And same with Professor Russell in lots of his metabolic studies, and then later on he became quite. And I used to laugh at him, and I said, "You never believed in psychotherapy," because we as postgraduate students had 1 day off at the Royal Free, and we could 1 day or 1 afternoon off. And I used to go to Tavistock. So I used to do it so quietly and secretly because I thought Gerald Russell would be upset that I'm going into Tavistock, etc. But I managed to do 3-year course. I also went to personal analysis. So you believe me, I was like a genie. And I, away from Pakistan and not knowing what I will be able to do, but I had this world in front of me and the world was open for me. So I did everything. When I went to America, another world was open to me. But, as luck would have it, I had to come back to Pakistan. My mother was ill and there was no job. They wouldn't give me a job in any place because I didn't have the domicile. And the Karachi domicile didn't give you the jobs in large teaching hospitals where actually I trained. And so, and I must say, Zaki Hassan wasn't very helpful. I'm sure Norman Sartorius, he knows him very well, but he wasn't very good to psychiatrists. And long story short, I couldn't get it. But it so happened that I had applied for a job in Pakistan Airlines as a head of department of psychiatry. Can you imagine? 28, 29-year-old person, 90 pounds, looking much younger, but having all the degrees. And they doubted if I had all these degrees by post, MRC Psych, my state board I was given that, etc. But they couldn't believe it. Anyway, I was taken because the person who was selected He had a heart attack and he couldn't come. So I believe in the power of prayers. I think my mother prayed hard that this girl should get a job, otherwise she probably won't come. But anyway, she said, if 6 months you don't feel happy, you can go back. So I got this job. And long story, then I had to excel in aviation. I became one of the top aviation psychiatrists, etc., etc. But I continued. The advantage is I feel very strongly with all students. Never lose hope. And if you're a believer, keep praying and keep working. And don't leave a minute or a chance to learn something. Because I didn't have children, I didn't have anybody around. I was single, full of beans, wonderful friends in England. And I still have such wonderful friends. They're all consultants, all everywhere. In fact, George Schmuckler, who was another dean, and he became the professor. He got this Professor Aubrey Lewis chair at the Maudsley, was my colleague. We shared the room at the Royal Free. So, I'm so proud and so happy that it's strange. Miracles happened with me. So please, I am one example, living example, which says that you work hard. And if you're good and you have prayers of your parents, I believe in prayers, so you'll get everything. And now I am just here, and people like Bulent and all are very kind to me. Javed has always been super, super. He left Pakistan long time back. Again, I think he has a problem like me. He couldn't get jobs in Lahore, and there were a lot of nepotism, etc. And Pakistan now is in hell. I don't know how to say it. It's sad. But this is my story. Thank you.
Thank you very much for your detailed and descriptive answers. So actually, I had a question just about this. You said that you have lost your father very young. I'm sorry about that. And we see that familial or cultural or personal factors like this have impacts on the students' career choosing. Like they decide to, like you have decided to choose cardiology first and then psychiatry like this. And I want to ask for you all and other professors, what were your situation? What were the cultural or personal factors or familial factors for you that lead you to first decide to be a doctor, to choose medicine, and then choose psychiatry? And have you ever thought that psychiatry is not right for you, or how come you can decide that psychiatry is the right place to be for you to be in? And what are your advices for medical students on this?
I think brilliant questions, brilliant questions. And I think I should be taken as a case for medical students. I was 17 and my father was army officer. He was in Second World War. He got Victoria Cross. And a very handsome Pathan. He was a Pashtun, from Pashtun, from Ghazni. Very handsome man. And his father was also army officer. So it's a family of army officers. And my mother came from a family of civil servants, lawyers, etc., barristers, etc. It's very interesting how they got married. It's all destiny. It's all fate. But there were two very good-looking people. My mother was so handsome, so beautiful, and my father was so handsome. And then they had me. I was the second child, but my first sister was stillborn. No, not stillborn. She died premature, and I was the second one. And I think, not unfortunately, but I sometimes think I was the darkest child at that time, because they were all very fair, rosy skin, and so was my mother. But they loved me because I was hyperactive. Even as a little child, I was always active and very sweet, apparently, according to my mother. I wish I was looking for my childhood pictures, but somehow I cannot send them to you. You won't believe I was like a real doll. And my aunt was very good. She would put me bows, and I would wear all these lovely frocks and things. And I was always daddy's girl. And my father, from the very childhood, my father, I remember when my brother was born, and we were in Rawalpindi. He was born in the CMH, in the Combined Military Hospital. And there I saw the ladies, lady doctors, wearing this beautiful uniform, and they would wear it in winter. They would wear their jacket, and I asked, and I always used to say, I want to go in army. And that time, my father said, "Oh yes, you can go if you become an army doctor." So my reason for becoming a doctor is that I wanted to wear that uniform. And I wanted to be like my father. That was daddy's girl. And all these years, I worked very hard and I dreamt of that, etc., etc. Till I was in the final year in medical school. And at that time, as my father had died, my mother had to go to another city where we had our lands, etc., to look after them. And you know, the army people don't have, at that time, didn't have any money like what nowadays all over the world, army people are making a lot of money. But at that time, they were not. They just had pension. So she had to.
Could you please summarize?
Shorten it.
Yeah, please.
Yeah.
Do.
Quickly. So I was put in a hostel. I was in a hostel in the last year. And there, you see, there were a couple of girls, two girls. One had a carpopedal spasms, you know, she got hysterical or something. And I thought it was calcium deficiency. And she went to all my professors, medical professors, or you name it. And they all said, oh, this is this. And they didn't look at her very nicely because they thought she was hysterical and this and that and the other. There was another who used to have asthma and had cortisone. So she became paranoid. And again, the professors were not very good. But she knew Harun's family, Dr. Harun, who was my mentor. So the mother took him to there. And again, as being the leader everywhere in the hostel, they said, Uneza, you come with us to the clinic. And I was a medical student living in a hostel. So I went to the clinic and I saw this very, it was like Sidney Poitier. It was very dark. And he was sitting there, but very charming. And he was asking questions. I was, by that time, I think in fourth year. And I had read all about, little bit about psychiatry, this, that, and the other. And I said, oh, it's this or that. I can't remember. I was arguing with him. He was so polite and so nice and so kind. So he asked me a couple of other questions. And I was taken aback comparing him to the professors who were other, you know, the medical, all the physicians, etc. And my mentors, my medical mentors in the medical school. And he was very good. And then gradually I got very interested. And with her, I used to go to the clinic. And then during that period, I realized that I had to stay with my family. My mother used to be outside the city, and I had to stay with my younger brother and sister. So I couldn't do night duties. I wanted to do cardiology at that time, but I couldn't do that. But I had decided I'll do psychiatry. And again, no post-graduation in psychiatry. But anyway, I met Dr. Harun and I said, well, look, this is what it is. He said, oh, well, we don't have a SHO here, but I'll try and get you a job, a special job where you can work with us. And eventually we will have the DPM kind of thing in Karachi, in the College of Physician Surgeons. So I worked there. That's how I got interested. And what was the other question? I forgot.
Well, let the other question
you asked me some other,
for another time, please.
Sorry? Why did I tell you what? That's why I got interested in psychiatry. Because I thought psychiatrists were very polite and they were special people and who would deal with things which, you know, patients would be suffering and nobody else would understand. So I thought that's fascinating.
Please let us listen to the other guests.
Yes, I think I've said enough. Yeah. Yes, sorry.
Thank you very much. Thank you.
Thank you very much, Dr. Niaz. It was very good to listen to you, but we have limited time, so
I know.
sorry.
I know.
So I can ask another question, but we haven't heard from Dr. Jenkins, so I think I will address this question to you, if it is okay. So I want to ask, do you remember the first time you entered in a psychiatric clinic? And what was it? What was it? Oh.
She looks lovely.
Yeah.
Thank you.
I wish I had my childhood pictures.
Yeah, it's very good. It's a very good picture. So, do you remember that time? What was it like for you? And it was always your, is it always your idea to be a psychiatrist back then, or what were your thoughts?
No, I arrived in psychiatry completely by accident, really. As a preclinical medical student, I'd spent 3 months in Tanzania, which was a wonderfully sort of formative experience, which I loved. I was in a research institute up in the Usambara Mountains, the East African Institute for Malaria and Vector-Borne Diseases. It was when Tanzania, Kenya, and Uganda were in the East African community and shared their research expertise and so on. And to answer your question about whether you can go and work in a country with a different language, of course, I was fortunate because it was sufficiently close, I guess, to colonial days that most adults in Tanzania still spoke English. Later on, that would not have been the case, but at the time, this was 1970, it was the case. But of course, I was also working alongside a research team of Tanzanians and British and American scientists who all spoke the local languages as well, Swahili and the local language. So I was sheltered. So I wouldn't want to say that it's straightforward to go and work in a country with a different language, which one might not be expert in. But anyway, for me, those 3 months were just brilliant, and I came back really wanting to do tropical medicine. But then for my clinical training, I was very lucky. I went to St. George's, and the dean was a psychiatrist, Arthur Crisp, a very forceful psychiatrist, an expert in anorexia. And so psychiatry was reasonably prominent in that medical school. And we had our 6 weeks of psychiatry. And one of my consultants that I worked with then was Jean Paykel, who was a very influential psychiatrist, lovely man. And he was the person who, certainly for the UK, invented community psychiatric nurses, really. He really pushed them out across the country. And so from the early 1970s. So that was formative. And I may say that of my cohort from St. George's, none of them went into specialist medicine or surgery. They all either became GPs or community physicians, or I became a psychiatrist, and I think another one or two also did. So we were a different cohort to our predecessors, who all wanted to do specialist medicine, specialist surgery. Anyway, it wasn't my intention at that stage to become a psychiatrist, although I really enjoyed it. My intention was still to go back to tropical medicine. But I married a lawyer who said he couldn't work in Scotland, let alone Africa. So I decided to be a GP, and I was applying for jobs in psychiatry, geriatrics and pediatrics. And the first job I happened to get was the Maudsley. And I went, loved it, stayed, and never looked back, really. So in a way, psychiatry kind of seduced me. And when I look back on my preclinical era, I was reading books by people like Lang and Sass and so on, which lots of students do read. So I obviously had an interest in it, but I didn't know that was where I was heading. But I've never been bored. I've never regretted it. And yes, it's been gripping, really. So that was my journey in a nutshell. And I was fortunate, as Unisa says, opportunities flash by and you have to seize them. So I don't know if you have any other questions.
Thank you for your answers. Actually, one of my question would be, is there any time that you all regret about this choice, or you always thought that it was the best way for me, best career for me? And you have just answered it very well. And do we have any other thoughts on this?
Well, I did not want to do psychiatry. It was, in fact, there was nothing else to do. So I wanted to do pediatrics because I liked pediatrics very much. But then my mother was a very famous pediatrician. And I thought if I take pediatrics until the end of my life, I'll be known as the son of the famous pediatrician. So I didn't like that. So
you speak a bit louder.
Psychiatry. And psychiatry at that time was a terrible discipline. It was really terrible. There was still, I remember my visit to a hospital in the United States, which had 13,000 patients and 14,000 staff. It was a town that was living on its own. It was the choice of methods which were available has been very limited. The insulin comas and electroshock And more or less, that was all that was available. And these hospitals were in a very, very bad way. But since there was nothing else at the time, I couldn't get my, I didn't want to do pediatrics, and the others, they were all closed. I went into psychiatry. I didn't like it very much in the beginning, and I didn't like it much later either. I gradually thought that psychiatry has to be has to think about ways and patient contact a little differently. I think today the situation in psychiatry is completely different. We are now uh, having medications which we can prescribe. We are still within the center. This is my photograph when I was getting my medical school graduation. I'm the one on the right, not the one on the left. Um, and so I went into this discipline, and I think today psychiatry is becoming more and more popular. There are now many people who would like to do psychiatry, and in fact, in some countries, they are number one and number two among postgraduate education altogether. And I think partly because psychiatry has really become medicine. Uh, Most of the doctors in other disciplines are relying on machines, on laboratories, on various other things which are not the human contact. Psychiatry remains still today, although it has access to diagnostic procedures, is still relying on talking to people and trying to help people because they have a problem, because they suffer, because we listen to them as they suffer. So I think that it's becoming a different discipline altogether. It's really replaced the medicine of yesterday. Yesterday, the general practitioner was listening to the patient and was trying to advise him and speaking to his family and speaking to the children, doing all sorts of things, trying to understand the patient and using a lot of empathy in doing so. That was as time went by. Now, the general doctor as well as the specialist, they rely exclusively on machines. It's unbelievable how many machines they have to utilize now, or how want to utilize. I was recently in a hospital for a minor thing, and I saw a doctor for about 7 minutes, and I was in various investigations for about 2 hours. I never saw any. I mean, these are the people, the technicians who were doing the machines were very nice people, and I spoke to them. In fact, they gave me advice about my illness. It wasn't the doctors who helped me. So I think that the medicine as such has changed. In many places in general medicine, it has lost the very essence of medicine, which is understanding people, listening to them, trying to help them, etc. This is all gone out. You now have machine after machine after machine. And doctors, when they don't have access to machines, they feel hopeless and helpless. Psychiatry still relies on the contact with the patient, listening to the person, trying to understand what they are saying, trying to compose somehow an advice that will help people to live further, which many of the other doctors are not doing anymore because they are so obsessed by the laboratory and by various other investigations. So that I think that your question whether psychiatry is popular, I think it will become more and more popular as time goes by because it is so close to true medicine, while the other disciplines are becoming much more close to laboratory science and to a variety of things of this type. So maybe one thing you asked another question earlier when you were introducing about studying in other, going to other places and working in other countries, etc. I think that decision must be yours. If you leave your own country, you're losing what is the most crucial value, which is early friendships, people with whom you went to school together, people who know your family, people with whom you were going to medical school or other people. These people are your community. And you go to another country, you don't meet any one of those who were with you while you were small. You only meet people whom you meet when they are adults. And I think that is a very different type of relationship and friendship. So I think it's perfectly possible to work elsewhere. I myself am not working in the place where I grew up. It's possible, but it does represent a loss in terms of adjustment and incorporation into a society and the community. As far as language is concerned, you all speak wonderful English. English is becoming a sort of lingua franca, a language that is used very widely. So language should not be a problem anymore, I think, for anybody. Although in psychiatry, really, you do need to have the language of the patient as well as the language which you are speaking with your colleagues, because it's impossible to understand the patient in a language which is not his own. So I advise you to do the following thing, which I think is perfectly possible today. There is the World Medical Association, World Medical Student Association, which has a variety of exchange programs. It's very helpful to go to another place to see what it looks like, to make some friendships, to get to know people, and then go back home. And do this maybe every year during your holidays. It's not, it's perfectly possible to do it there. You can now go by bus from Istanbul to Berlin for 20 francs, 20 euros, which is a really opening the door to a variety of places where one can go. But I would go, if I would suggest, go to other places for a short while to get to know the people, to see what it's like, and you will discover that your place is not all that bad. We are always thinking the grass is greener on the other side. Well, there are many advantages of being at home, which you cannot replace, no matter how much money you might be making.
Thank you for your answers. It was very inspiring for us. So actually, my other question would be, like you said, medical students can do internships and other things in other countries and everything. My other question will be, what can medical students who is interested in psychiatry can do outside the medical curriculum, like research, internships, students clubs, or maybe can they be a part of VPA or APA, maybe some organizations like that? Do you advise to do this to them?
My feeling was, just to start, I'm sure that Rachel and Afzal and others will speak. I think that it is helpful to volunteer for shorter periods, for a few weeks, for a month, in a department of psychiatry, to see who's there, to see whether you like the people, to see whether it's your cup of tea. And if you do it for a month or 2 months, people will be very happy to have you. Most places in the world would accept a medical student. They are young and beautiful and full of ideas, etc. So they're welcome to come, and they spend time. Then you will see, nobody can tell you what you will like. So being there and volunteering for a month or two in various places is a very useful way to finding out what your future career should be.
Thank you. I also think that it is very important. I had the opportunity to make a clinical elective in United States when I was a medical student, and it was really life-changing for me. It was a good opportunity. Yeah.
And also remember, just one word, you remember also that even if the country or country is one country, the places in which you are very different. So that if you volunteer 1 year in one town and the other year in another town, you will find that these people are very different and give you a very wide set of impressions and ideas that will be helpful.
Yeah, the clinical practices may vary from institute to institute, so it will be important for us to see and then choose about this. So my other question would be, we all know that medical school can be very challenging, and we have high depression and anxiety rates among medical students. So, do you also remember having difficulties during medical school or during residency? Like, for us now, you are living legends of psychiatry, but we are curious if you had any difficulty back then, and how could you manage them, and what are your advices for medical students to build up their resilience through this journey?
You meaning personal difficulties?
Yeah, about that.
Yeah. Well, I think that it is at all instances useful to seek advice of people. Maybe what your major worries are really nonsense, or maybe they really need a person with whom you have a close contact, etc. And very often people do not go to consult anybody because they're afraid or ashamed. And it's a pity because it is very often possible to get good advice from people if you go and see them. So I would say do not hide. If you have problems of sorts, don't hide them. I think go and talk to people, talk to a specialist or a general practitioner, or for that matter, another doctor who is a doctor whom you know in your family, wherever, to find out what that might be. We have seen in many medical schools, medical students who have been too shy to go to see anybody, and very often they get to the wrong people in the end, and that's not helpful. 90% of the people have problems, so you should never be ashamed of having a problem. It's only humans who have so many problems. I think that one shouldn't be ashamed of having a uncertainty or a problem or something like that.
Yeah, although you can go, Dr. Nias. Were you about to say something, Dr. Nias, or?
Yeah, I just wanted to say, as a girl or a woman or whatever, as I said, that my father had died, my problem during my clinical years was to be attached and to do the night duties, you see, like in gynae or in medicine. And that was very difficult because my brother and sister were alone at home. And mind you, this is very different culture, Pakistan, and they were much younger than me. And I couldn't stay there for the night. So I remember I talked to I didn't actually talk. One of my friends had a car, and she also, for some reason, had a mother not well. So we would work till 12 o'clock or 1 o'clock, and then we'd just quietly slip. And I remember one day as we were slipping down, and the RMO it's great fun. He supported us, and we'll do all the work. We'd go to emergency, we'd clerk patients, do everything. But by 1 o'clock we would go because she had a car and she had a reliable driver. Because at that time in Karachi, girls couldn't go alone, so she would drop me, and this is what we continued. But one day we were caught, and this professor was supposed to be very strict. And he was tall and dark, and he said, "What is this happening? What is?" And he said he used to in Punjabi, "Mahal, what is it? Making fun of these." So we just stood there, and I told him this is what my problem was. Then he looked at me and he patted me at the back and he said, "No, you've done well, and we'll see how it goes." And then I told him very quickly, "I'll be in the hostel." And then he said, "Yes, then you can do some extra nights, etc., in emergency." And that's what I did. So my professors also were very kind. And so these problems do happen. Somewhere, for example, pharmacology early years, the preclinical years, pharmacology I found very difficult. But then the second professor came, he was great. So, I mean, things do happen. Now, medicine isn't easy. Even anatomy at that time, we had proper dead bodies. We didn't have these what you call models or whatever. We had proper dead bodies. They would smell and hands would be dirty with the fat of these dead bodies. So, I mean, we tried everything, but it all happened. Our teachers were wonderful, I have to say. If 2 or 3 were awful, the rest of the ones, the younger ones, are very good. And then you have a good teamwork. Your friends, your colleagues, they all help. So that's what I wanted to say. It passes. It happens in any profession, I'm sure. But it passes. And that one thing you said, will you ever do psychiatry again? I would say yes, always. I love what I did, and I wish if I have a second reincarnation, I'd be the same girl. But probably I do little things different in my personal life, but not professionally. That's all. I'm very happy of what I am. And it's very rewarding. Believe me, when a patient comes, and I do psychotherapy also, so it's like clinical, plus I'm a psychotherapist as well as a clinical psychiatrist. But it's not a traditional analytic thing because this doesn't happen in our part of the world. So I've never ever had any regrets, and I love it. But can be very depressing. Yes. I mean, it can be very depressing. Patients, when became desperate, or somebody, one patient during my during my training in psychiatry in England, in Hampstead, committed suicide. In fact, one of the colleagues, a junior colleague, registrar, he was very depressed and he took an overdose and he was found on Hampstead Heath. That was very shocking because one of the colleagues died. And I think he was very severely depressed and something happened. So, yes, deaths do happen. But fortunately, not in my case. I've never had any of this. But suicidal attempts, yes. And they can be painful, certainly.
Thank you for your answers. I think that Professor Javed will say something.
Let's hope.
Yeah. If allowed, may I ask some words of wisdom from Professor Sartorius? You have been instrumental in adding new dimensions to the psychiatric training, especially one of your favorite areas is the leadership development. Do you think that we, psychiatrists as role model, can influence the promotion of psychiatry among medical students? And what would you suggest? How can we achieve that? And can we try to bring this as a part of the curriculum when we are having the postgraduate training in psychiatry?
With your permission, Madam Chairman, I think that is a crucial question which you're asking. I think that many psychiatrists are not very good models. They are, unfortunately, not showing what psychiatry can do. They are not practicing what they are preaching, and they are, in fact, making people go away from psychiatry. And I think that it is, in a way, one of the things that would be very important is to filter more carefully who is suitable to be a psychiatrist and who should maybe go to some other discipline and to some other place. Because many of the psychiatrists who we are seeing today are not doing well for our discipline. And I think that one has to admit this. But the skill, I think that there are several skills which one should learn, whether this is from psychiatrists or from other doctors. They would be very helpful for psychiatry and for others. One of the most important skills, which is unfortunately not being taught in many medical schools, is the skill of listening. How do you listen to people? Because psychiatry is a dominant in that respect. It, in fact, asks you to learn how to listen, asks you to interpret how people are telling you things, etc. And I think that's one of the skills that psychiatry could offer to the general medicine. There are several other skills like that which psychiatry could offer. But in order to do this, we would have, and I think I'm speaking now of the World Psychiatric Association, of others, we would have to think a little bit of what is it that a psychiatrist should learn and what is it that he can teach others to do, so as to define their role a bit more clearly than it is at present. I think we have reached the time of
Yes, kind of, but if you have time, we can always continue. We are very happy to hear your thoughts.
Yes.
Thanks.
I think that one of the maybe on the things that is there are some books which have been written over time about lives of doctors. And I think one of them which is particularly striking and made people become very interested in much better doctors than they were, was the book that was written, it was called The Fighters Against Death, which was by a person by the name of Cruyff. It's an old book, but it gives profiles of 15 doctors and the ways in which they lived. I think something that you might wish to look at. I will send the exact reference to Professor Choshkun to maybe if he can make it available to others.
Thank you for your advices. Yeah, role models are very important while choosing careers, and like you said, it's important to have good and I think not wrong role models. Like you said, there are so many of them, and it's important for us to have role models like you to see and
Yeah,
to
remember
do
that
as
for being a good doctor, the role model which you are seeking does not need to be a doctor.
Mhm.
And doctor is composed of two pieces. One is the human being, and the other one is the skills. And those are not necessarily, sometimes you can learn more about medicine from a good person, from a person who is in your surroundings, who teaches you
Mhm.
how to have empathy, how to understand people, how to help them, what to do about yourself at some times. And I think that part is a very important one. The other part, medicine, are skills and a variety of facts that you learn, which are very helpful. But
Mhm.
learning how to be a good doctor is not necessarily only from doctors. Maybe your parents or your friends or somebody else whom you will find. So try to seek role models among people whom you admire and who you think that they could be maybe become your mentors in time, or with whom you can talk and think, etc. The doctoring as such, learning how the skills of medicine, is a different proposition altogether. The central part of a doctor is, in fact, that he is a human being with a feeling with others, for others.
Mm. Yeah, right. You're right. It's very well said. We sometimes forget that doctors are also human, and we I think during medical school, and sometimes we all focus on just on the medical skills, and we forget sometimes about being a human being and having empathy towards others and listening to them. And in psychiatry, it's also very important to listen to others, and it's a very important skill both for psychiatry and actually
There's
for
a little thing,
other fields.
there's a little thing which you might wish to do sometime, and that is you take what is that is called the skill of trios, where you take three people, you put them together, and you ask them, one of them to be the examiner, the doctor, and the other the patient. The third one observes them.
Mhm.
And then you rotate the roles so that after somebody has been a doctor who is examining, he now becomes a patient who is being examined and observed. And then the observer becomes. So the three people who are in this game are, in fact, all three experiencing the three roles: viewing a medical intervention, listening to a patient, and being a patient. It's amazing how much you can learn about yourself when you do that. What things that nobody tells you are wrong, things that nobody tells you that are wonderful, things that you don't think that you see or that other people see when you're doing them. So it's a very simple thing to do. It takes about, if you do it, maybe altogether 45 minutes, uh,
Mhm.
but it's extremely instructional.
Yeah, it's a great advice. Thank you. Maybe we can organize something like that in the seed group, Dr. Joshkun. If you also want that, maybe we can make smaller groups and we can organize that, and it will be helpful for students. Thank you. So my other question will be, what do you think that yeah, we have talked about it a bit, but I will ask some more things. Like the place of psychiatric education in the medical curriculum. Like we have some internships for psychiatry, and I remember that my psychiatry internship was like 2 or 3 weeks, and it was just in the psychiatry unit, psychiatry inpatient unit. But we haven't learned much about outpatient clinics, and we haven't learned at all about community mental health or everything. So, what do you think that the place of psychiatry in the medical curriculum must be, and um, how can we have doctors experience about psychiatry? Uh, during our medical education. Like, not everybody should be a psychiatrist or must be a psychiatrist, but I think that every doctor should know a bit about psychiatry or understanding people or community mental health. And how can we integrate this better in our medical curriculum?
Well,
May I say,
I don't want to be the only one speaking, but I think that one of the things that is tremendously important is to learn a variety of skills that you normally do not learn. You should learn how to listen. It's probably the most important skill in medicine. You should remember that, also remember to learn how to give advice, which is a very complicated skill. In order to be you can advise anybody about anything, but to make your advice count and to make people accept it is a big skill. But you should also remember that nowadays the 90% or 80% of all patients do not have one disease. They have more than one condition. They are having what is called a multimorbidity model, so that a person who has a psychiatric problem usually has physical problems as well, and vice versa. And that therefore the doctor as such must have the skills which will deal with various kind of conditions which are there. And I think that that is something that makes psychiatry or makes psychiatric skills more useful. I do not know how much, how easy it is access to skills, but even if you were to read about the elementary skills of communication or listening, etc., would be something very helpful. And you can try this out with one another. You don't have to have a patient in front of you. Try to tell somebody something in a manner that will be making them do it. You'll find it's not a very easy thing to do, but it's a skill, elementary skill that you should have. Giving advice, listening, expressing empathy, which is a very important skill as well. These are all skills which are general for medicine. It so happens that psychiatry in the past was the one that practiced more of it. But I think that it's really at the center of medical professions.
Thank you very much. And another question, maybe it was a question from one of the...
Excuse me, Iram. Before we pass to another subject, I would like to remind one of our advisors in SEED group, Professor Parameshvara Deva. He passed away, and we should recognize him with his style of teaching in places outside the medical wards, in primary care especially. We shouldn't forget this. We should keep this in mind.
Yeah, you're right. And maybe, Dr. Coşkun, we can also hear about your opinions on this subject, because we know that you are working on community mental health. And can medical students be a part of this, or should they? What are your thoughts?
Yeah, of course. I also believe that medical clerkship or psychiatric clerkship should not be limited in the psychiatry ward or outpatient clinics. We should be able to go out of the hospital walls. And now I'm retired, but during the time I work, I used to go out, especially to community mental health centers with our students and residents. Such activities would help them to see what's going on in the environment, in the outer world, because in psychiatric wards, it's not possible to see all kinds of patients they are going to meet in the future. So we should try our best to be in touch with other branches, and especially primary care. Yeah. Thank you.
Maybe two more things to say here. the one is that we have been talking a great deal about community care. But what happens in the last maybe 20 or 30 years is that communities are disappearing. They are not there anymore. People have moved to town, the families have become smaller, the families don't live anymore on the same compound. Even in countries such as, for example, India or other countries, the total size of the household, which was more or less closely linked, has become extremely small, which means that the person who is looking after the person with an illness is becoming more and more stressed. And the carers are at present probably the most important priority for medicine. How can we help people who care for people? How do you help a daughter who has a father who is demented and who has two children and has to have an afternoon job as well? How do you help this person to survive, to stay alive, not to break down? And I think that that is an area which is a tremendously important and completely neglected. For example, people who look after other people, carers, are not teaching in medical school. They should be teaching you how do you look after a patient at home, because you don't know it unless you have yourself the experience of somebody who is not well. But carers are now showing being under tremendous stress because nobody else helps them. The family has fallen apart. There are people very often in various parts, so there's not anymore that. And the carer has a tremendous burden on his shoulders. He has to look after himself or herself, as well as about the patient, particularly chronic patient. We've made people live very much longer with the disease than ever before. So carers have 10, 15, 20 years of looking after somebody. It's a terrible burden. So what happens? Their physical morbidity has gone up sharply. Their mental morbidity has gone up sharply. And we are not doing anything to help them. We are not asking them for advice. We are not listening when they speak to us. We are not allowing them to come. And we are not thinking of how to help them to stay alive and well in order to continue providing care. There is only one country. I think Professor Javed will be present maybe at some of these sessions. The Royal College is giving a special prize to the best carer family in the country. Well, it's a symbolic thing, but the basic principle of that is that you, as a doctor, you cannot work with the patient alone. Your duty is to think of how to maintain the carer alive and well, because he is doing the care, not you. Okay? Normally, as a doctor, you see a patient for 20 minutes and he goes home. And then he's at home for the months and somebody else is looking after him for a month. So who is this person who is looking after them? Are they well? Are they happy? Are they having problems? Will they break down? They have a huge increase of breakdown and burnout for carers that we are now seeing. And that is something that a modern doctor cannot overcome, cannot put aside. He cannot deal with the patient alone. He must think of the patient and the person who is looking after the patient. Whether these people who are there, who provide care on a long-term basis, are well done. Now, this is becoming more important for two more reasons. Number one, the population structure is changing so that the number of people who are elderly and survive with disease is becoming larger and larger. And somebody must look after them. It's so bad now that, for example, in a country like China or Bangladesh, they had to put special laws into practice to force children to look after their parents because they refuse to do it. Because they say, we have a life of our own. We have to live as well. So how can I look after all these people? So I think that it's a duty of the doctor nowadays, after he has spoken to the patient, to speak to the family member or other carer for long enough to understand what he can do to help the carer, not the patient. The patient, he will do his normal duty, but the carer duty is a second one, which is very important. In some countries, they have what they call peer support groups, in which a persons of the same age or persons who have retired will in fact help somebody who is unwell. But by and large, in most countries of the world, for all chronic diseases, there is usually one or two other people who look after the patient. That is becoming our priority, to keep them well, to keep them healthy, to keep them continuing, to encourage them, to listen to them, to learn from them. I think that we are not doing. And I think that is, if you think about the most important change in medical practice, is the switch from the central attention of the patient to the patient and the people who look after him, which is now becoming essentially important. And without it, I think that our system is breaking down. We are now seeing this in so many areas in which this is happening.
Yeah, all right. I wasn't aware of this during medical school, that caregiver of patients, they also need help. They also need.
They need help, and they will, for example, you will ask them what you can do for them. It would be ideal if the government is, in some countries they do, gives them a financial money, gives them money so they can hire somebody to help in the house. That's one way to do it. Maybe there is some other way, but essential in this is to ask them, how are you living, you, the carer? What can I do to help you? Is there anything that we should change in order to help this? There's a new model of social work now that has been introduced in Holland, which I think is maybe I'll just mention it. Previously, the social worker was sitting and listening to people who came with problems of social work, and he was doing whatever he could. Then in Holland recently, they changed it. They say no more of that. You, the social worker, you will have to look after the following 10, 15 families. That's your duty. So in those families, there is one person who is not well, but the social worker comes to the family in the morning. He sits down with them. Can I help you in any way? Do you know how to put down the tax returns? Do you have problems with the police? Do you have this? He helps the family as if he was a son of that family. And he is not only a son, but he's very knowledgeable about the social system and can help them. So he spends a little time with them, and then he goes to the next family, and then he goes to the next family, etc. And his patients, his 20 families, are his life. He doesn't come to the hospital anymore. He comes to these. And what happens is that the social workers are very happy about this system, and the families are truly feeling that they have suddenly got somebody who helps them in a real, concrete way to do their work a little bit better. In Holland, they've also got other things that they're doing. For example, there is what they call a holiday admission. Sometimes they would admit the patient, a chronic patient, to the hospital for a fortnight so that the family can go on holidays. Because if they don't, they'll break down. And then you will have the patient for 100% of the time. So that there are many ways, but I think it's centrally important to consider what can I do, and certainly listen and talk to family members and carers longer than to the patient.
Yeah, right. I think during medical school, it's imposed on us that we should evaluate the patient and we should care about patient, but it's not very often said that we should care about the families, and it's very hard for them to. And I think that in psychiatric field, it's more important and it's harder because often psychiatric patients can be unaware of their situation sometimes, but their families are aware of the situation, and it's harder for them. And yeah, we should help them too. You're right. Thank you. And I have.
I think Professor Sartorius has touched the crux of psychiatry. This is really, I think, after all, he's a master of us all, mentor of all. I think this is psychiatry, taking care of carers to rehabilitate. I've seen places in Holland, and they're amazing places. Even in London by that time when I was leaving, they had social workers visiting these places, and they were put in small houses, not halfway houses, but something like that. And it was like also like, there was a nurse, there was a doctor coming every morning seeing these patients, and also because they stopped the large mental hospitals and chronic wards in the hospitals. So they went on the and the most important person is the family. By just being so involved and feeling guilty and responsible that nobody's taking care, their lives are gone. And you must have heard of folly a family, a woman living with a husband or a daughter is schizophrenic. She also becomes like that. And the moment somebody else gets involved, and the other healthy person gets better. So I think, thank you, Professor Sartorius. As usual, you touch the most important aspect which students should know. The other thing which I just wanted to add, besides everything, I honest to God think the reason why, I don't know whether I'm a good or a bad, I think I read a lot. When I went in England, I had a lot of time. And, I used to read anyway, I was from the convent school. So I read the classics, Dickens, this, that, and the other, Shakespeare, of course. Then in America, and even during that period, all those 9 years, 10 years I was abroad, I read every novel, Ibsen and Russian novels, Dostoevsky, and you name it, and then about musicians. So you need to know about everything. And that enhances your sensations, your thinking, and then you can also think of, see, for example, when I started doing private practice, and I had left PIA, and I just wanted to do proper psychiatry, taking care of these chronic patients. So I saw in Holland, there was a place, Netherlands, there was a place where they had music therapy. They had a room with a lot of drums and things and flute and things, and they were playing that, and the patients were playing that. And so many mute patients, catatonic patients came out and started talking. So that is another very important thing. Then I think in Lahore, Afzal Javed is gone. In Lahore, his I think uncle or mentor there, he also started this cultivation thing. They had little farms where these chronic schizophrenics or chronic patients would work. And it was very interesting. They lived in the rural side and had a happy life. So I think one should think of these chronic patients also, though it's a 1% schizophrenia and this and that, but they live for long and the families suffer a lot. So very important, but you must read all these novels. And all Shakespeare is psychiatry. Believe me, it's psychiatry. You read Ibsen, you read Dostoevsky, and the more you read, the more you understand. And I think Somerset Maugham and other people, and I think Lord, and then the wonderful novels, Wuthering Heights, and all these. And I think I forgetting the names of Hollywood movies. I mean, they are so fascinating. I saw Autumn Sonata. I think it was Ingrid Bergman's thing. I was amazed the relationship between a daughter and a mother, and how the daughter felt miserable, and the mother was one of the well-known. She became very well-known. I think she was, I'm again mixing up. I mean, it was so beautiful. I came back. I think it was late night movie, and I started thinking about my mother when I was very 17. She had left for that, but I loved my mother. There it was different. She was an actress. She had a very good life, and there was this girl there. It's these are beautiful, emotional. Not only they give you other aspect of people suffering in loneliness or suffering because they're alone and they haven't got any father. So please read, listen to music. This all enhances your understanding of human beings. And definitely taking care of carers is psychiatry. Thank you very much.
Okay. Thank you so much. We have some more questions from chat, but I think we haven't enough time. What do you think, Dr. Coşkun? Can we ask them, or should we organize another event for this?
Yeah, I was thinking to do something like that because we have so many things to ask, so many things to share. Let's make this the first session, and maybe next month or some other time we can have another similar session.
Yeah, it's a great idea. Yeah, we have so many things to learn from them.
Okay, well, learning is mutual. We are also learning from you.
Thank you. I would like to thank you all for participating this event, both for students and you, our senior educators. And thank you for all your answers and explanations. It was a very enlightening and fruitful session for all of us. And it was a very valuable opportunity for us to have and listen you here. I hope to see you all in the upcoming events, and I'm hoping to meet you again. Thank you for all.
Yeah, maybe as a last word, I would also like to say that we could try our best to answer the questions asked by Bartu and Irem and the other colleagues through communication before even the next meeting we are going to organize. I think Professor Sartorius is going to say something.
Well, I was just going to ask maybe that you could, as a rule, number one, I think that it would be helpful if people who have a question could write it down and pass it to the chairman on this chat or somewhere else. Or alternatively, even before the meeting, he says, I know that you will have Dr. So-and-so in your group. I'd like to find out the following thing and have a list of questions in advance, maybe even share the questions among all participants, that we know what is going on. That's one. And second, I'm delighted that Bartu joined us in face. And I also hope that in the future you can have it a rule that everybody's face will be seen in these meetings which you are doing. It's very nice to see you all, and God helping, we'll meet somewhere else. So I'd like to know what you look like, and so as to say hello when I see you.
Can I ask you, Dr. Sartorius, Dorman Sartorius? I'm dying to ask, what is it that keeps you so young? And so, your mind is brilliant. You've got a brilliant mind. And I get emotional. I may be good with clinically with the patient, but you're so brilliant. I mean, this is one of the crux which you touched. The crux of psychiatry is caring of the carers. And I have seen patients, families suffering. And in fact, I wanted to write a book about it and how mothers have gone through it, how sisters, how the siblings felt so useless because the mother was concerned about the sick patient. And they felt very guilty that we were normal and this poor brother and sister is not well. And they left the world, they didn't think of, living their own lives. And their lives were all sort of like combined with this sick person. And but leave it aside. No, honestly, tell me, what is your routine? Do you eat almonds? Do you have 8 hours sleep? Do you go for walks? What do you do? Please, if there is a secret, tell us. Tell me at least. I'm getting very tired. I've got rheumatoid arthritis, and I'm getting, I want to write, I want to do things, but all these ailments bug me. Please tell me what is it? What's the secret? If there is a secret, if there is a secret.
Could you please, just before asking or giving the floor to Dr. Sartorius, can I suggest to have this question to start the next meeting?
Maybe.
Because if he agrees after saying a few words, maybe...
He has to agree. He has to agree. We are the junior colleagues, and we always looked up at him, and he's always turned up to be I've never been disappointed hearing him or talking to him. He's wonderful, and his wife is most lovable person. I think one of the secret is that he's got this wonderful wife also. So yes, I agree. But please help me. How do I get rid of this misery of rheumatoid arthritis and feeling tired? And I'm still not that old, I'm nearing 70. So I need some help.
I'll tell you three things that I think help. Number one, you cannot change very much. This is your genes. They give you a certain amount. Number two,
Sorry.
And number three, you can change. Number two, for me, I think of great importance is to find a partner with whom you can be whom you trust, who trusts you, and is being together with somebody, which is of tremendous importance, whether it's a husband or a wife or a son or a grandfather, it doesn't matter. But it's a relationship with a partner, with somebody with whom you can share things, whom you can trust, and who can trust you. That's the second very important thing.
The
third one, which is not too bad.
First two I missed. What was the first one?
Is genes. Genes, what God has given you, and your parents have given you genes, have made your body. I mean, it's something the heredity which you have. This is not something you can change very much. But that if you're lucky, you have it, and if you don't lucky, you less have it. But the two things which you can change is, number one, finding yourself a partner, whether it's male, female, old or young, it doesn't matter, but it must be a partner whom you can trust and who trusts you. And I think the third one is very important, is to not be too bound by the prescriptions, what you should be doing at certain ages. We are sort of particularly in our age, we are saying, you are too old, you shouldn't be doing this. You should go to bed at 9 because that's very important. No. You should do what you feel is right to do, and never mind what age it is, and never mind that people say you can't do this. No, I can do it because I like to do these things. And so I think having a independence of your action, having a partner, and having good genes are probably explanations that one can take into account. But
I think I know all my best friends have died.
All
my best friends have died, and my partner is in fact not well. He has fractured both his legs, and when you look at his X-ray, he looks like Iron Man. He's become stubborn. So I think these are the things which got me down. And I try my best, and I don't have family. But I think my greatest support is my faith in, I'm a believer. And my prayers and the spirituality helps me. But other things, and I think going to conferences has helped me. So I was going to Morocco for this psychodynamic conference. And of course, the plane returned from Turkish Airlines didn't take us to there, and etc., etc. So I think that's why I'm becoming a little depressed, because my only solace is getting out of the environment, getting into a new country, feeling great professionally. And my presentation was so well liked on Zoom that they are publishing it in the journal. So it's a great honor. But day to day, it's becoming difficult. The weather is so hot, and my arthritis bugs, and no friends now. And I get so tired, I don't want to go out. But I agree, I have to change. I have to get into exercise, and I have to make some boyfriend. I have to make a boyfriend now. I think I'll have to do that.
Yeah, we have to finish. Thank you for your understanding.
Yes. Thank you.
Thank you. Thank you, Madam Chairman. You've done a very good job. Thank you very much. And thank you, volunteer again.
Brilliant.
The other people should speak a little bit more and should be alive and smiling at us. That's very important.
Yes.
Thank you very much.
Bye-bye. Thank you. God bless you all.